Understanding nutritional status is fundamental in public health nutrition. It helps us identify individuals and groups at risk of undernutrition, overweight, or obesity, and guides interventions to improve health outcomes. With rising rates of obesity and metabolic diseases, assessing nutrition has become more critical than ever. This video explores the main anthropometric measurements used in public health, their strengths, limitations, and how they inform our understanding of population health. By the end, you'll appreciate why accurate assessment is the cornerstone of effective nutrition policy and practice. Anthropometry refers to the measurement of the human body. In public health, it includes height, weight, and body circumferences. These measurements serve as indicators of growth, nutritional status, and risk for diseases like diabetes and heart disease. Whether in clinical, research, or community settings, anthropometric data provide a snapshot of population health and help track changes over time. They are essential for monitoring trends, evaluating interventions, and setting health priorities. Standing height is a basic yet powerful measure. It reflects cumulative linear growth and overall body size, combining the lengths of the legs, trunk, neck, and head. In children and adolescents, height is a sensitive marker of growth and nutrition, highlighting issues like stunting or excessive growth. For adults, final height can be linked to risks for metabolic diseases and cancer. Accurate height measurement requires proper technique, including correct head positioning and multiple readings to ensure precision. Sitting height measures the length of the trunk, neck, and head. By subtracting sitting height from standing height, we estimate leg length and assess body proportionality. While not routine in public health, this ratio is valuable in research, as it reveals differences in upper and lower body growth. Such differences can be linked to metabolic disease risk, providing deeper insights into how body shape relates to health. Body weight is one of the simplest anthropometric measures. Its accuracy depends on factors like scale calibration, clothing, and hydration status. In weight management, changes in body weight are often used to track fat loss, though some lean tissue is also lost. While easy to obtain, weight alone doesn't distinguish between fat and muscle, so it's best interpreted alongside other measures. BMI is a widely used index combining weight and height to classify individuals as underweight, normal weight, overweight, or obese. Calculated as weight in kilograms divided by height in meters squared, BMI is quick, inexpensive, and useful for large-scale assessments. However, it has limitations. It doesn't measure body fat directly or distinguish between fat and muscle. This can lead to misclassification, especially in muscular or ethnically diverse populations. BMI categories help classify nutritional status. Underweight is defined as a BMI below 18.5. Normal weight ranges from 18.5 to 24.9. Overweight is 25 to 29.9, and obesity starts at 30. Higher BMI categories, such as severe and morbid obesity, indicate increasing health risks. These categories are used in clinical assessments and population surveys to monitor trends and guide intervention. BMI is linked to health outcomes in a J-shaped curve. Both low and high BMI are associated with increased mortality. High BMI is strongly related to type 2 diabetes, hypertension, and heart disease. Despite its widespread use, BMI is only a proxy for body fatness and can misclassify individuals, especially those with high muscle mass or different body compositions due to ethnicity. BMI is non-invasive, quick, inexpensive, and simple to perform. It's useful in both clinical and epidemiological settings, allowing for easy comparison across populations. BMI accounts for differences in height and is independent of age and sex in adults, making it a practical tool for large-scale assessments. Despite its advantages, BMI has notable limitations. It measures weight, not fatness, and doesn't differentiate between fat and lean mass. BMI also fails to indicate fat distribution or skeletal muscle mass, leading to potential misclassification. It may not treat all ethnicities equally, as body composition varies across populations. For these reasons, BMI should be interpreted with caution and used alongside other measures. BMI cutoffs may not be appropriate for all ethnic groups. For example, South Asian populations tend to have higher body fat and central fat distribution at lower BMI values compared to Europeans. As a result, lower BMI thresholds for overweight and obesity are used in some Asian countries. This highlights the importance of considering ethnicity when interpreting BMI data in public health. To address BMI's limitations, researchers sometimes partition BMI into fat mass index and fat-free mass index. This requires additional measurements, often using technologies like bioelectrical impedance analysis, BIA, or dual-energy X-ray absorptiometry. These methods provide a clearer picture of body composition, helping to distinguish between fat and lean tissue, which is especially useful in research and growth studies. Waist circumference is a key measure of abdominal obesity, which is closely linked to metabolic risk. Unlike BMI, WC specifically reflects visceral fat, the type of fat associated with higher risk for type 2 diabetes and heart disease. Measuring WC is simple, but the site of measurement can vary, affecting comparability. And ethnicity-specific cutoffs help identify individuals at increased risk. Waist circumference is measured using a flexible, non-elastic tape. The measurement site can differ. Some protocols use the level of the umbilicus, others a point above it. For accuracy, it's best to measure over light clothing or directly on the skin, and to subtract clothing thickness if needed. Proper training is essential to minimize errors, especially in very obese individuals where locating the true waist can be challenging. Waist circumference cutoffs differ by sex and ethnicity. For example, Europid men are at increased risk if WC exceeds 94 cm, while South Asian and Chinese men have a lower threshold of 90 cm. For women, the cutoff is generally 80 cm across groups. These cutoffs help identify those at higher risk for metabolic syndrome and related diseases. Combining BMI and waist circumference provides a more complete picture of metabolic risk. For example, someone with a normal BMI but high WC may still be at increased risk for disease. Tables combining these measures help clinicians and researchers assess risk more accurately and guide interventions for overweight and obesity. Hip circumference, measured at the widest point, is used alongside waist circumference to calculate the waist-to-hip ratio, WHR. WHR distinguishes between fat stored in the abdomen and hips, with higher ratios indicating greater risk for diabetes and heart disease. However, measurement errors can occur, especially between different observers, which may limit its use in large surveys. Waist-to-hip ratio, WHR, is a strong predictor of cardiovascular and metabolic risk. Men typically have higher WHR values than women, and cutoffs are used to identify increased risk. Interestingly, higher hip circumference may be protective, acting as a reservoir for triglycerides and improving glucose tolerance. This adds nuance to how we interpret body shape and health. Newer measure, waist-to-height ratio, WHTR, combines waist circumference and height. Unlike BMI, it doesn't require weight measurement, making it practical for field use. A WHTR above 0.5 signals excessive abdominal fat and increased risk for hypertension and heart disease. This measure is independent of age, gender, and ethnicity, and supports the simple message: keep your waist less than half your height. Skinfold thickness measurements use calipers to estimate body fat by measuring the thickness of subcutaneous fat at specific sites. While once common, this method has been largely replaced by newer technologies due to its lower precision and higher potential for error. However, skinfolds are still used in some settings because they're inexpensive and portable, but require careful technique and training. Bioelectrical impedance analysis, BIA, is gaining popularity in public health nutrition. It estimates body fat and fat-free mass by passing a small electrical current through the body. BIA is quick, non-invasive, and provides more detailed body composition data than BMI. It also helps monitor skeletal muscle mass, which is important for tracking sarcopenia in older adults. BIA offers several advantages over traditional methods. It's relatively inexpensive, portable, and provides quick results. Unlike BMI, BIA reduces misclassification by directly estimating body fat and muscle mass. This makes it a valuable tool for population monitoring and for identifying individuals at risk of obesity or sarcopenia. In large-scale surveys, participants may self-report their height, weight, or waist circumference. While convenient, self-reported data are prone to bias, people often overestimate height and underestimate weight, leading to underestimation of BMI and obesity prevalence. This highlights the importance of direct measurement whenever possible for accurate public health data. Anthropometric tools are just as important for children and adolescents as for adults. Height is a key marker of growth, while weight status must be monitored due to rising obesity rates in youth. However, fixed cutoffs can't be used for this age group because growth is highly age and gender dependent. Instead, percentile charts are used to interpret measurements relative to peers. Percentile charts graphically represent the distribution of anthropometric variables like height, weight, BMI, and waist circumference in a reference population. Each percentile shows a child's position relative to peers of the same age and sex. For example, the 50th percentile is the median, while the 98th percentile marks the top 2%. These charts help identify underweight, healthy weight, overweight, and obesity in children. In clinical settings, percentile charts are often used, but for population surveys, Standard deviation scores, SDS, are more common. SDS indicates how far a measurement is from the median in standard deviation units. For example, an SDS of +10 means one standard deviation above the median. This approach allows for more precise comparisons across populations and over time. BMI percentiles are used to define overweight and obesity in children. In the US, the 85th percentile marks overweight, and the 95th marks obesity. In the UK, similar percentiles are used for epidemiology, with slightly different cutoffs for clinical referral. International cutoffs have also been developed to align child percentiles with adult BMI thresholds at age 18. BMI in children has high specificity but poor sensitivity. It rarely misclassifies healthy children as overweight, but often misses those with excess body fat. This means BMI can underestimate the true prevalence of overweight and obesity in youth, leading to calls for better assessment tools, especially as childhood obesity rates rise globally. Waist circumference percentile charts have been developed for children and adolescents. WC is linked to several metabolic risk factors, including adverse cholesterol profiles, high blood pressure, and fatty liver. WC levels in youth have risen faster than BMI in recent decades, highlighting the growing problem of abdominal adiposity in young people. Newer technologies like BIA allow for the creation of percentile charts for body fat and skeletal muscle mass in children. These charts reveal gender differences in fat patterning and help identify children with high fat mass and low muscle mass, even if their BMI is normal. This can signal early risk for conditions like sarcopenic obesity and poor glucose metabolism. Body fat and muscle mass charts reduce the misclassification seen with BMI alone. They provide a more accurate picture of a child's health, helping practitioners identify those at risk who might otherwise be missed. This supports better targeted interventions and more effective public health strategies. Selecting the right assessment method depends on the study's objectives, population age group, and ethnicity. Practitioners must weigh the validity, cost, and practicality of each method. Training data collectors is essential to ensure accurate and reliable measurements, especially when using more complex techniques or self-reported data. Self-measurement and reporting of height and weight can introduce significant errors, especially in large-scale surveys. Overestimation of height and underestimation of weight are common, leading to underreporting of overweight and obesity. Whenever possible, direct measurement by trained personnel is preferred for accuracy. Emerging technologies like BIA and advanced imaging offer new opportunities to distinguish between fat and lean components of body weight. These methods can be integrated into public health surveys with minimal additional burden to participants, providing richer data for monitoring and intervention planning. Before adopting new assessment methods widely, further validation studies are needed. These studies compare new techniques with established methods to ensure accuracy and reliability. Only with strong evidence can we confidently use these tools to identify individuals and groups at risk for metabolic and degenerative diseases. Accurate nutritional assessment relies on well-trained personnel. Whether measuring height, weight, or using advanced tools like BIA, proper technique minimizes errors and ensures data quality. Ongoing training and standardization are essential, especially in large public health studies where consistency is critical. Understanding population references and percentile curves is crucial when assessing children and adolescents. These references provide context for interpreting individual measurements, helping practitioners identify deviations from typical growth patterns and target interventions where needed. Body composition and disease risk vary across ethnic groups. Practitioners must consider these differences when interpreting BMI, WC, and other measures. Using appropriate cutoffs and reference data ensures more accurate assessment and better health outcomes for diverse populations. Anthropometric data are essential for monitoring trends in undernutrition, overweight, and obesity. Regular surveillance helps public health professionals track progress, identify emerging issues, and evaluate the impact of interventions. This ongoing monitoring is key to effective nutrition policy and planning. Accurate assessment methods are vital for evaluating the success of public health interventions. By measuring changes in height, weight, BMI, WC, and body composition, practitioners can determine whether programs are achieving their goals and make data-driven adjustments as needed. In summary, public health nutrition relies on a range of anthropometric measures: height, weight, BMI, waist and hip circumferences, skin folds, and advanced tools like BIA. Each has strengths and limitations, and the choice depends on the context, population, and resources available. Combining measures often provides the most accurate assessment. As technology advances, new methods for assessing nutritional status will continue to emerge. Ongoing research and validation will ensure these tools are accurate, practical, and accessible. The goal is always to improve our ability to identify and address nutritional risks in diverse populations. For practitioners, it's important to select the most appropriate assessment tools for your population and objectives. Ensure your team is well trained, use standardized protocols, and be aware of the limitations of each method. Combining multiple measures and considering population-specific references will yield the most reliable results. Anthropometric assessment is central to public health nutrition. While BMI remains widely used, its limitations mean it should be combined with other measures like waist circumference and body composition analysis. Accurate data collection, appropriate interpretation, and ongoing training are essential for effective nutrition monitoring and intervention. Assessing nutritional status in public health settings is a complex but vital task. By understanding the strengths and weaknesses of each anthropometric measure, practitioners can make informed choices that improve health outcomes. As new technologies emerge, staying updated and validating new tools will ensure continued progress in the field of public health nutrition.